Morning friends, welcome to the IC on Lasik for the general ophthalmologist. We intend to cover all the topics from evaluation to the procedure, complications and how to manage a refractive practice. Professor Kapoor has talk in another hall, so we are just changing the order a bit. I invite him to talk on SMILE first.
Thank you, Shashi. Good morning, everybody. I think this hall is going to be full with refractive, and more refractive. So there's so many ways you can skin the cat, but what is the best way is what you feel comfortable with. You can buy machines. Technology comes it's come as a cost. You can buy smiles. You can buy femtos. But if you're not convinced in what you're doing, you can never convince the patient that this is the best for you. So I'll be just sharing with you my experience with SMILE for the last, we have it for last 3 years now. Okay, so what exactly is SMILE? Initially when you started Lassic, what came first, the egg or the hen? I think the excimer machine came first. So we started zapping the corneal surfaces. Your wires are loose here, I think. So we started cutting the surface off like a PRK. Then we got the blades. We got a hang of blades, all these Hansertomes and any Morias and all. So you raise a flap, like an ambassador car, you open the bonnet, treat the engine, and you put it back. So you got a flap and you put it back. Then came the evolution when you hit the femtoseconds. Now femtosecond did a corneal flap making, which was very precise as compared to the blades. So your standard deviation was about plus minus 20 microns, which was fantastic because the blades were unpredictable. So once they got a hang of cutting the cornea in one single plane, then the second thought came, why not cut anterior and posterior both and take a lenticule out, rather than cutting it all around 360 degree and making the cornea weak. So the flap and zap has become flap and flap only. So you cut two complete lenticule and take it out. So you have to buy one machine only. All right, so the first people who started this was, it was Secundus, in which he created a flap, but he lifted the lenticule, entire lenticule from a big incision. It was actually creating a flap, 360 degree almost. Then Blum et al. Came to SMILE, in which the incision went to 2 millimeters. Now everybody in SMILE is actually using 2 millimeter incision. So what is good? If you're cutting more cornea, the two basic things which are happening in refractive surgery when you do on the cornea is you're making this cornea weak for life. Every procedure on the cornea, when you cut any amount of collagen, will make it weak. So which one is a lesser evil is what you can pick up. Both are evil, right? So lesser evil is the one which is SMILE, because you're not cutting 360 degree. So the innovation is much better in these ones. The strength of the cornea is there. It definitely becomes weaker than the pre-operative eyes in both scenarios. But this paper from ophthalmology tells us that it's much better, much safer for people who have thinner corneas, in which you can still take a chance with the SMILE as compared to Lassic. Okay. The second is the dry eye. When you cut the nerves 360 degree, the biggest thing you're causing is that all the innervation has gone down. So in this study, they found out that the dry eye is definitely less in cases of SMILE patient checked at 1 month, 6 months, and 1 year follow-up. There was a meta-analysis in which the 5 studies were taken care, in which they compared the dryness in both the groups, and they came to the conclusion that yes, the dry eye is definitely less in these patients, and all the fibrils, the corneal nerves are well preserved in these patients as compared to the Lassic. So Lassic is what is the basic talk here. You must do Lassics also, but if you can take a step up and you can just go to SMILE, but SMILE also has its own problem, the cost and the complication, which I'll be discussing in some time. So basically this step, what you do in this one is you cut the posterior lenticule, side cut, anterior lenticule, and incision, you take it out of the eye. I'll just show you a little video here. I think that will clarify everything. All right, so that's the blinking light. So there is no infrared capture in this eye, so you have to make sure the eye is in the center. And what I did was I put the infrared on. So with infrared on, you can see the pupil, which you can't see otherwise, and it's all centered, and you start firing. Now this is a posterior cut. It's a lenticule, posterior lenticule cut, which has to take place first, because if you cut the anterior one, you can't cut posterior because the light is not going to go through this opacity, which you created there, the bubbles. So that's the posterior cut first, and then the side cut, and then comes the anterior one. So anterior can be done easily because the anterior fibers are still clear. And this goes about 0.5 beyond the previous cut. And that's the incision, so that's about it. Now everything is cut. Now you have to go inside, split it up. And this was my first surgery of smile which I did. So this is actual recording. It's not been edited at all. So whatever thing I'm doing, fumbling or whatever, this is what the way it is. So people say it's a long learning curve. I don't believe that. If you're an average cataract surgeon, you can manage it very well. So I'm going very slowly, gingerly. So do you cut it from the posterior and interior? When you dissect from anterior to posterior. So you're dissecting the anterior plane first. And once you dissected the anterior, then you make a posterior little flap on the posterior, not all the way. And this is going to take little time because this was the first surgery which I operated. So I just wanted to show you the first one. I've been done about more than 1,000. Now we take even, I think, less than 50% of this time which we are doing there. Okay, so once you've done anterior, then you go posterior in that one. And if you notice, my lenticule is going to be free from all the sides. And you just hold it and take it out. All right, so you can see the lenticule, it's clear from all the sides now. It's been separated from all the sides. So you just hold the lenticule and it's taken out. So learning curve there, but yes, the most important thing is the patient's cooperation. If the patient is cooperative, and I was not holding the eye in this surgery. So most of my fellows who start, I tell them to hold the eyes properly and do it. Gradually over a period, if you develop confidence that the patient is good, you can do without holding, and this is what it looks like. Okay. So this was a patient with a Lassic, and that's a patient with a smile a minute after the surgery. So what are the shortcomings of this one? When the smile came, they never had a good correction for the cylinder. But last year in October, they have started giving a cylinder till -3. So you can do from -1 to -10, depending on what is the residual belt thickness. And pre-op workup for smile is the same as the Lassic. It's not having advantage there. So whatever patient you can do a Lassic on, you can do a smile also. Right? So I'm sure that lots of people are going to be talking about Lassic, so I'm going to skip that one. Ectasias can be seen with PRKs, with Lassic, as well as smile. So even the smile is going to make your cornea weak. So pick up the lesser evil is what I said. So your all residual bed thickness and PTA should be taken care of in these one. The complication could be two. One, the patient is not cooperative. So he moves the eye and the suction ring loses the suction. Second, you're firing the beam, but it's not cutting the cornea because something comes in between. It could be a mucus on the eye, a dry cornea. So at that spots, you'll get dark spots, and that's where the cornea is still sticking to each other. So it will be difficult to dissect. So I'll just show you some videos in these ones, and then we'll finish it off. Now see, these are the patients done. They look horrible because they're, come on. Yeah. So you see there's a struggle going on there. Lenticule has been held from the side, and only the half lenticule come out. See, it's not a complete lenticule. So you go back again, hold it, and take it. Now this video is one of the worst surgeries I've seen, but the result next day was patient was 6'6". So you can go back and take it out, the lenticules. So there's no point in leaving the lenticules behind. You can pick it up, and if you have an OCT guided microscope, you can do it very easily on the same day also. So once that's taken care of, that's gone. You can have suction loss at the beginning of the surgery or at the end of the surgery. So this is what happens with suction loss. Now suction loss is more in these patients that came to the Lassic because the amount of suction pressure is low in smile patients. Come on. आएगा तो वो टाइम निकल जाएगा तब तक. Anyway, so now this is what you see, a black spot here. So that is where the cornea is not dissected yet. So when you're splitting the cornea, you have to be a little more crude here. You have to be little with a little force. You have to push it open and do it. So we've done about 1,000 eyes for now. So the basic minimum I've done is -1.5 to 1.75 to -9. At 1 week, all these patients were 6x6. In the early phase, we used higher energy in these months, and we were getting more of OBLs, and it was taking recovery time was a little longer. But now most of these patients, first day, they are 6x6 because energy have been reduced. So suction loss was seen in a few patients, and the black spots were seen in a few patients, which I think is a part of the learning curve, and eventually this all settles down. So shortcoming of the software is that they don't have a 1 mm incision. In fact, in some time they might have two 1 mm incision, and you can split cornea all around. they don't have a OCT as such on the machine, so you might have to take the patient to the other microscope sometime if the lenticule is left behind. The foot control is not there for the zoom. So every time you have to zoom, you have to use the hand back with the knob. So if you're doing a procedure, you have to leave the instrument, go to the microscope, adjust the focus again and go back. So that's a little cumbersome. So with the request, I think Zeiss people have put foot pedals on these machines now. So to conclude, the smile is a simple, there was no loss of vision in any of these patients, and it's predictable and there was no regression. And all these patients, at the end of 1 year, the dryness and the hysteresis was pretty good in these patients. So it's quite a safe procedure. Thank you very much.
Thank you, Dr. Coker.
If you have a question, you can take.
We will take the question later on, sir, because we are a little running behind time.
So
yeah, thank you.
Right, thank you.
We now start with first evaluating a patient who comes for LASIK. Dr. Sartaj Grewal from Chandigarh is part of Dr. Grewal's group. They have a largest refractive practice in North India. And I'm looking forward to your talk, Sartaj, on evaluating the patient.
Thank you, sir. So good morning, everyone. I would like to thanking Dr. Shashi Kapoor for giving me the opportunity to be a part of this instruction course. Today, let's learn the approach to interpreting corneal topography and pachymetry. Now, it's important to remember that both of these, they are the foundation for a successful refractive surgery and a happy patient with a stable cornea in the future. There are three different techniques for determining corneal topography. The first and oldest is placido-based and began with the placido disc and was followed with the video keratoscope. The next is the slit scanning system, utilizing the OpScan as a combination of slit scanning and placido imaging. The third and most popular used today is the Scheimpflug-based devices, which will be the Pentacam, the Sirius, and the Galilei. Now, the information that these modern topographers provide us is overwhelming, and it can be very easy to just get lost in the maze that is created by all this information. So it's very important to narrow what you want to look at. So let's start by just looking at the 4-map refractive display that these machines give. You start off by looking at the elevation maps, the pachymetry map, the sagittal curvature map. You need to look at the keratometry values for the front and the back surface of the cornea. You need to look at the corneal thickness data that comes out and some of the data related to anterior chamber. It's important to adopt a strategy to be able to browse and analyze this information in an efficient manner. So first and foremost is always identify that the report that you're looking at is for the correct patient. It's a very simple thing, but sometimes it can lead to a lot of mismanagement. The next, you need to confirm the quality of specification. Now this specifies the quality of the data that has been captured. It should be a white box with OK, otherwise there is some missing information which has been extrapolated by the machine and will be shown in a yellow box or a red box. If this is the case, it is ideal to try and capture the data once again by repeating the scan. Next, we look at the pachymetry. The pupil center is the corneal thickness, which is corresponding to the pupil center location, and its coordinates are important to evaluate angle kappa. And normally the x coordinate should be less than 0.2 millimeters, which corresponds to less than 5 degrees. The pachy apex represents the thickness at the apex of the cornea, and the computer considers the apex as the origin of the coordinates. The thinnest location which is the location of the thinnest point of the cornea, and the difference between the thinnest location and pachy apex normally will be less than 10 microns. And the y coordinate is the one that is important to look at, and it's most often normal when it is less than 0.5 millimeters. But if it's between 0.5 and 1, it'll be very suspicious, and if it's more than 1, then it is quite abnormal. Now, compared with ultrasound pachymetry, which measures thickness at only 1 point, the Pentacam can generate 50,000 data points to describe the true thickness, and a normal pachymetry map will always have a concentric shape. Next, let's look at Kmax, which is the maximum curvature power of the whole anterior surface of the cornea and is expressed in diopters. A value of below 47 is suitable for refractive surgery, and a value between 47 and 49 can still be considered, but it is a moderate risk factor. Next, we look at the Q value, which is defined as the radial change from the center to the periphery of the corneal surface, and it reflects the corneal shape and the optical properties, including the refractive power, the spherical aberrations, and the aberration distribution. and a normal value will be anything between -1 to 0. Looking at the anterior curvature map, which represents the anterior surface dioptric power measured by the sagittal method, and one of the normal patterns which can be seen here is the symmetric bow tie, but there are a number of different patterns that can be observed on this. Now, it's also important to understand the settings for the machine, and when you want to choose these, it's important to remember that a 0.25 step, as can be seen all the way on the left, can lead to a lot of noise, while a 1 diopter step can lead to washout of all the details, and you can miss a lot of information. So a half diopter step has been suggested as the ideal value that best represents all the information we need. Coming to elevation-based tomography. Now, while the posterior imaging is very useful for determining the surface corneal curvature, elevation is what helps us understand and determine the overall corneal shape and the spatial thickness profile. Now, in order to make this data that we get clinically relevant, we need to compare it against something, and we usually will compare it against a best fit sphere, and which is constructed by fitting the reference sphere surface as smoothly as possible to the data surface, as can be seen in this diagram. When we look at the elevation maps of the cornea, we can see a symmetric hourglass pattern. We can see certain tongue-like extensions or irregular patterns, which should be matters of caution. The elevation map has a color scale where anything anterior to the best fit sphere is in red, anything posterior to it is in blue. Normal values will be anything less than 12 microns, but when anything between 13 to 15 is suspicious, and anything more than 15 will be a risk factor. And the difference between the front and the back surfaces should ideally be less than 5 microns. If a patient has a keratoconus on a best fit sphere, we'll see it as a conical protrusion because it will be above the best fit sphere. Another great feature of some of the modern tomographers are differential maps, which can help us track the progress of this patient from scan to scan, and we can easily compare them two on the same screen. Next, we come to the Bell and Ambrosio enhanced ectasia display, which is an excellent tool for identifying patients who are at risk of ectasia. And the best part is that it gives the information in a very colorful display, which are very easy to pick up. It's lesser chances that you'll miss anything that is irregular. Now, the first two standard elevation maps that come, they display the baseline relative elevation of the cornea to the best fit sphere. Below them are the anterior and posterior exclusion maps. These are enhanced elevation maps which display elevation data with the best fit sphere calculated using all the raw elevation data located outside a 4 millimeter circle, which is centered on the thinnest point of the cornea. Next, we come to the D value, which takes 5 different indices, taking into account the variation in the front surface, the back surface, the pachymetric progression, the thinnest point, and the thinnest point displacement. And it takes all of these 5 parameters and then performs a regression analysis against a standard database of normal and keratoconic eyes. Any value less than 1.6 diopters is normal. Anything between 1.6 and 2.6 is a little suspicious, and anything above 2.6 is abnormal. And it's shown to have a very high sensitivity and specificity for picking up patients with keratoconus and ectasia. The thickness profiles that are provided, the corneal thickness spatial profile, it describes the average progression of thickness starting from the thinnest location to the corneal periphery. And the percentage thickness increase is the percentage progression of the CTSP. We need to look at the red line, which is the data for the patient that you're examining. And ideally, it should follow the curvature of the black dotted lines that are there. The ectatic corneas, they will thin out and they will change their curvature more rapidly as they go from the center to the periphery of the cornea. And that is, it's very useful to help differentiate this between just what is a normal thin cornea and an actual ectatic cornea. Average values between 0.8 and 1.1 are normal. Anything above 1.1 is suggestive of ectatic disorders. So a quick slope like this is suggestive of ectatic disorders and must be cautioned. The Ambrosio relation thickness values, this is a concept that combines the thinnest pachymetry values with the pachymetry distribution. And this facilitates, again, the identification of an abnormal cornea from just a normal thin cornea. And ideally, it should be over 400 microns for patients to be suitable and considered for refractive procedures. So let's just discuss a few cases. So again, we'll go step by step. We look at the quality of the scan, which is okay. We look at the pachymetry values, which appear good in this case, along with the coordinates. The Q value falls within a normal range. The pattern on the anterior curvature is normal. The keratometry values are within a normal range. Anterior elevation is normal. Posterior elevation is normal. The bad display is also good. So this would be a suitable case for refractive surgery. Next, we come to another patient, and again, the quality of the scan is okay, but the thickness of the cornea it's quite thin, especially the thinnest location is, again, there's a significant deviation also in the coordinates, which should be automatically a red sign for us. Although the Q value in this case is normal, but even the anterior curvature, if you look at it, we can see a claw pattern over there. Even the K max in this case is 48.6, the anterior elevation is 28, posterior elevation is 47, and even the bad display is giving an index of 7.41. So this patient quite clearly has keratoconus and should be counseled for C3R. But sometimes you can have cases like these which are not quite so obvious, neither here, neither there. Again, the quality is okay. The pachymetry is within normal range. The Q value is okay. The anterior curvature is a symmetric bow tie. It's just against the rule. But if you look at the spatial thickness profile, it does tend to sort of fall away steeply as we go towards the periphery. The K max is 47, which is borderline. Anterior elevation is, again, normal. The posterior elevation is showing an irregular pattern. The ART values are lower, which again should be a little bit of caution. Maybe this is a patient where you want to consider combining a C3R along with the refractive procedure, or at least counseling the patient that he's at maybe a slightly higher risk than normal. Coming to pachymetry, there are basically two techniques. There's optical pachymetry and there's ultrasound pachymetry. In optical, you have Scheimpflug, slit scanning, ASOCT, and specular microscopy. All the different techniques that are used for pachymetry, they show a very high correlation, and it's probably best to just use the same machine you use for topography to also obtain your pachymetry values. Always remember, measure twice, cut once. Thank you.
Dr. Grewal, the third case which you have shown, if the age of the patient was 50 years or 45 years, what will you consider? Because most of these patients, they have a fairly good resistance to develop the keratoconus.
Yes, but at 45, 50, I mean, what I'm considering for refractive surgery will be very different. I'll have to look at is the patient looking at some kind of presbyopia correction. But yes, older patients, you're right, there is a natural cross-linking that is occurring. They will be stable.
The second thing is, will you keep the epithelial mapping along with that, especially the older patients? Most of them have a normal epithelial cells, and recently all the suspected cases which are of the 40 plus, even though he's showing the keratoconic pattern, they have a normal epithelial cells, and 3 of these patients we did a PRK at present. We did the 3 PRK, we're just waiting how they behave. Because epithelial mapping, I personally feel is a very sensitive thing as far as the atresia is concerned.
RC, are you saying that it should have been abnormal if it was really keratoconus, the epithelial mapping?
Even if it is faunal keratoconus, you get the sensitivity first from the epithelium, you pick up very early.
Thank you.
Before even you can see something like that.
That's right.
Thank you. Thank you, Sartaj, for an excellent presentation. Our next speaker is Dr. R.C. Shah, who will be, I've requested him to talk to us. He's more of a scientist, in spite of being one of the largest refractive and cataract surgeons in cataract multifocal. He has done about 12,000, but a scientist basically. He's done a lot of work on depth of focus, mainly related to the IOLs, but I feel it has a lot of role because of the change of cornea that we produce. You know, it does alter the spherical aberration, and I've requested him, and he'll tell us something about depth of focus.
Dr.Shashi, today I've got to share the depth of focus, how to do right. This is probably the first statement in the world where we are neutralizing the other factors which are responsible for depth of focus. And recently I started applying into my Lassic patients. We did about 30 patients. It's a very initial stage of telling something about whether it's working or not. But I'm very, very, very positive about the approach which I had. The depth of focus, the definition is, depth of focus is a lens optic concept which includes cornea as well as the lens. that measures the tolerance of placement of image plane in relation to the lens. For us, it's a clarity of vision of the various focusing plane without changing the position of the eye, especially for near. The factors which are contributing for the depth of focus is size of the pupil, aberrations. It's a very small contribution as far as the IOL is concerned, but it's going to have a very large contribution as far as the Lassic is concerned, and the design of the IOL. I started the depth of focus mainly for multifocal lenses, and then I thought that if you can measure some good depth of focus to find out and evaluate the quality of these lenses, even though the same lenses, one batch is good, the second batch is not so good. So if you do this depth of focus, all of us will be able to detect the best IOL available as far as the multifocal and trifocals are concerned, and the new EDOF lenses which are available in the market recently. I studied 300 patients on OPD scan 3. The pupil size is approximately 4 mm in photopic and 6 mm in the scotopic condition in a younger patient, especially less than 30 years of old. It is 1 mm less in older patient, especially 60 plus. This is the data of the Indian population. The smaller the pupil, it adds to depth of focus and needs to be eliminated to find out the actual performance of an IOL in depth of focus studies. Not done so far. All the IOLs and the Lassic patients, especially the bifocal, EDOF, trifocal, varifocal, gives a good range of depth of focus at present when the pupil size is small. So these are the factors which are very important. One of them is spherical aberrations. A small amount of spherical aberration, if you leave it behind, either in Lassic or in cataract surgery, it improves the depth of focus significantly. Always undercorrect the spherical aberration as far as the IOL surgery is concerned. Contribution to the depth of focus is minimum, so it was not included when I did my studies in IOL, but it is very much included when I started with the Lassic patients. Okay. The depth of focus is done for distance. Remember, we always do for distance with undilated as well as the dilated pupil as far as the IOL is concerned, for the best corrected for distance. The size of the pupil is measured with dilated and undilated conditions in a dark room with OPD scan 3. The depth of focus is measured between from +2 to -3 at half diopter difference. The graph is plotted on the same paper, dilated as well as undilated, to compare between the two. All the measurements are done for distance and by changing the add to the distance correction. This will tell us how much acuity of vision for different add, thereby how much the IOL can tolerate, or even the Lassic patients. It is assumed that the results of distant depth of focus is more or less the same as near. Recently I started developing something for the near also. We are almost in the end of the study. So we'll have something where we'll able to find out the depth of focus for near also. We check the depth of focus for near by changing that is what I told now. I match the depth of focus for distance and near, they're more or less the same. So even if you are doing for distance, it almost works same for the near also. This is one of the bifocal lens which made by the Indian company. The red one is undilated and the dilated. So by doing these things, you are neutralizing the effect of the small pupil as well as, so the lens is working so well and they maintain the depth of focus fairly well. This is another patient which is most consistent. This is made by an Indian company. You see something which is going up. Here the depth of focus is so good because the light distribution has been extremely good for distance and it is maintained for intermediate as well as the near vision. This is the same thing which also you can find out on the point spread functions. How good quality of the vision which is there, and you can see the aberration which is there. It's very difficult to read because they are very small print. So spherical aberrations, recently I started doing for the Lassic patient. I did about 30 patients so far. Spherical aberration in most of the machines calculates at 6 mm. I reduce it to 4 mm zone instead, because when you read it, the pupil is never at 6 mm distance. You always at around 4 mm. So you don't need a spherical aberration which is 6 mm. Modifying the spherical aberration to near zero, either 0.1 or 0.1 on either side, plus or minus, at 4 mm zone whenever it is possible. In my machine, I have a limitations, that is NIDEC one. I can't go inside and change the various modes to decide what exactly I want to do it. So I have a limited access to the technology in NIDEC platform. improved depth of focus significantly in all the 330 patients in the age between 23 and 35. Here also, it's just a beginning of a new concept. I'm going to start with the older patient now to prove what I'm doing it. It is done with NIDEC platform, which does not allow to change the spherical aberrations in all the patients. आगे नहीं जा रहा है, boss. This is one patient. I have almost all the patients which is similar to that. Here you see the blue is the left eye. We did on a platform of CAT, that is a TopoLink. We could manage to get the spherical aberration around that. The first value is the Q value, and the second one is something which is either one. I don't remember which. One is Q value, other is spherical aberrations. And the red one is the left, which is done on a CATS. Again the same platform. We could manage to bring the spherical aberration nearby 0. And you see, when you are putting a 0, it is 6 by 4. And then even if you are changing 0.5 up to -3, it maintains 6 by 5 vision. That is what the concept which is there in the younger patient now at present. But probably this will also help us to get a good monovision. The whole concept of monovision will be enhanced, but without reducing the distance vision for one eye. This is one new concept which is there. Probably by next year we'll be able to get the complete idea even in the older patients. So to conclude, I am not claiming at present anything because it's still under the evaluations, and we'll have about 200 or 300 patients by next year. Depth of focus for distance is a very good tool to evaluate performance of any IOL. Surgeon must do all the depth of focus for all the multifocal lenses to find out which company has the best quality of vision. But so more important for this course is that in Lassic patient, this could be a very good tool to enhance the near vision instead of going for a mono vision. Thank you so much.
Thank you, RC. This is very good work and original work being done with the Indian population. I now invite the next speaker, Dr. Jivan Ladi, to talk about the surgical technique and the post-op management.
Thank you, Dr. Shashi. Respected seniors, teachers, and dear friends. नहीं वो कट करो वो नहीं यही खोला उसके बाजू वाला वही खोल रहा था ये वाला वही खोल रहा था
I think Dr. Kakadia might be able to help us in something where you can enhance this depth of focus on his own machine. Okay, we'll talk to them later.
Refractive surgical techniques and post-op management. There is no financial interest. Exam-eraser procedures in Lassic basically is called as a laser in situ keratoanalysis, and surface ablation name will depend upon how the epithelium is removed. If you are removing it by blade, it's called as a PRK. If you are removing by alcohol, it's called as a Lassic. And if you are removing by a machine, it's called as epilassic. ASA, advanced surface ablation, is nothing but the use of mitomycin C 0.2% with chilled balanced salt solution and use of bandage contact lens. ASA, what we do is we put proparacaine 4 to 5 times, which will loosen the epithelium before the procedure. We use 20% alcohol in 8.5 millimeter cup, which is kept for 20 seconds. Epithelium is peeled off easily. Thorough chilled BSS wash is given. Then you do laser. After laser, again chilled BSS wash is given. You apply the mitomycin C for 20 to 30 seconds, depending upon the refractive error. Again, you give a thorough chilled BSS wash. Put antibiotic bandage contact lenses kept for 3 to 5 days. Post-op treatment is vitamin C for 15 days, analgesic if required. Soft steroids are started after 48 hours, tapered over a period of 4 to 6 weeks, antibiotic for 8 days, and lubricants for 6 to 8 weeks. Lassic has different type, a simple Lassic, and you can have a wavefront optimized Lassic, wavefront guided Lassic, femtolaser Lassic, and relax smile or flex. In Lassic, we have a microcarotid pass, that is, if you are using a blade, IOP is raised to 60 millimeter of mercury, and it causes a blackout temporarily to the patient. Swipe the stoma after the ablation is over, remove the excess fluid, do laser, reposit the flap, give a BSS wash under the flap, and drying is kept for 2 minutes. Antibiotic steroids for 1 week, lubricants for 4 to 6 weeks, use of cyclosporine 0.5% for 6 to 12 months for a previous or a chronic dry eye or a chronic contact lens wearers. In Lassic, what does it do? It treats the refraction, but it adds to spherical and higher order aberrations. Wavefront optimized Lassic creates a spheric shape. It treats the refraction and treats the spherical aberrations, but there is no use of any aberrometer. Wavefront guided Lassic, you need to have aberrometer. It's a customized, it treats the refraction, spherical aberration, higher order aberrations, and you need to have aberrometer, and iris registration and pupil centroid shift compensation is required. This is just to show you when the ablation is going on, what you can see is the saccades. The eye is moving continuously. And this is where the active eye tracker is used, which is basically a three-dimensional system and which detects the movements of the eye in horizontal and vertical axis and shifts the ablation accordingly. I will not go into the detail of that. Relax eye uses a patient interface for docking. IOP is less than 30 to 40 millimeter of mercury. There is no blackout, so patient can keep on seeing the target light till the end. And there are 4 planes. Femtolaser cut is there: anterior, posterior, side cut, and incision. Dissect lenticule and remove. Interface, wash, gentle massage for the epithelial side, from the epithelial side. Use antibiotic steroid for 1 week, lubricant for 4 to 6 weeks, and again cyclosporine, as I told you before, for the Lassic. This is our own technique, which is called a SAFE, that is shearing applied force extraction. And you will see that basically it's a series of air bubbles which are created by the femtolaser, which is doing a first posterior cut, and then it does the anterior cut and the side cut. We take 2 millimeter incision at 110 degrees, so dissection is little bit easier. So in this technique of SAFE, that is shearing applied force extraction, what we do, we first locate the anterior plane and the posterior plane. So dissect a little bit into anterior plane and posterior plane. So you have 2 planes ready with you, and you can dissect accordingly. Now keep the hydration well during the procedure, so the cornea doesn't get dried up and you don't get SPKs post-operatively. And this is what we do, that minimal dissection, go to the opposite side of the wound and dissect 180 degree, then left half and right half is dissected, and we are now above the lenticule. We call this as a lenticle pressurized dissection. That is, we press onto the lenticule more while dissecting, so the surrounding stoma is not disturbed much, so the inflammation is less. Now we are going into the posterior plane. We just clear the central area and don't break the lenticule at this present stage. But once that is done, then what you can see is now we have broken the lenticule and we have cut on all 3 quadrants except for the left paracentral control, and that is taken out last. This is what is called as a SAFE. Now you put hydrate again, put a fluid inside, give vertical and horizontal massage. So basically it's a crenated border which is created by the air bubble. When you give a massage, they are ironed, and you will see that more than 95% of the patient are 6/9 partial or better within 2 hours of the surgery. This is the advantage of SAFE technology which was devised by us. Wavefront laser, basically instead of refraction, a map is treated. So what you see here is having a refraction, higher, lower aberrations, and this is what the map is seen. So this is the map, and what is the aim? Basically, this is the map, and which is a point spread function. We want to convert this map into a dot onto the macula, so your vision becomes more crisp. And this is what gives you a better vision than 6/6 and so called as a eagle vision or something better than normal. But a basic idea is to convert a map into a spot which will give you a clear-cut vision on a macula. Phakic IOL basically for high myopia and where Lassic is contraindicated. The USP of phakic IOL is that the optic zone gives 1.25 magnification at nodal point of the eye. This is why the quality of vision of phakic IOL is better compared to any corneal refractive procedure. In addition to that, you are likely to get improvement in the vision because of the magnification factor. If you see that loading of ICL is the most important part, and it is exactly opposite of the IOL which we use for a cataract surgery. Here, once you load the lens, the cartridge remains stationary and your forceps moves. So you you can see that the cartridge is at one place, it is stationary, and it's a forceps which is moving. Whenever you are putting the IOL in a cataract surgery, we have a habit of taking the cartridge a little bit up for the IOL to go inside. Here, exactly opposite. Keep your cartridge all the time horizontal and don't move it at all. So keep patience. This is going to unfold slowly. Being a collamer material, it unfolds very slowly. And see to it that it folds and unfolds onto the iris. So see to it that your cartridge is all the time horizontal. And don't come out till the time last part goes in. Okay? So this is the most important step. Now we can put the flanks of the haptic behind the iris, whichever technique you can use, whichever instrument you can use. This is the specific instrument for that. Now you can see that there is a hole into the center, and you can see that visco is coming out. So don't press onto the optic part, but you can press onto the little bit onto the edge of the optic so that more fluid will come out. So this stage needs a little bit more patience. Spend as much time as possible for removal of visco, and you will not find the IOP spike post-operatively. Thanks a lot.
Thank you, Jeevan. Our next speaker is the Keynote Address. And it's a very interesting topic, refractive surgery in children. Thank you, Professor. Welcome.
Thank you, Dr. Shashi. And thank you, my great friend, Dr. Rajesh, for having me in this prestigious meeting, giving me great opportunity to strengthen the bond of the Indo-Egyptian collaboration in scientific issues. So my talk today about one of the most crucial and controversial subject in ophthalmology. And we are the refractive surgeons always struggling with the pediatric ophthalmologists about this. To leave our patients with unilateral high error and anisometropia with their glasses for a life or turn to the refractive surgery. So, starting with this consideration, the laser vision correction, when mentioned, it means always unilateral procedure, never bilateral. And quick introduction about anisometropia is a condition where there is a difference of refraction between both eyes with more than or equal to 2 diopters, either myopic, hyperopic, or antimetropic, in which the patient or the child get one eye myopic and the other eye is hypermetropic. The treatment options should be in this order: the spectacles, the first line, then the contact lenses, if available and tolerable, and then shifting to refractive surgeries, including the laser corneal refractive surgeries and the phakic IOLs. The aim of treatment is for the prevention and treatment of the anisometropia and subsequently the anisometropic amblyopia. The amblyopia simply means that the eye and the brain don't work in harmony. there's misconnection between the eye and the brain, and the eye is typically normal, while the amblyopia is the difference between both eyes' visual acuity of 2 lines or more. Actually, the amblyopia is the most common preventable cause of the visual loss in children. So we are in need for awareness programs for parents and as well as the ophthalmologists. Stages of treatment which I respect in all my works. The first stage should be the glasses, only the glasses correction, either the full correction or the partial correction till reaching the full correction, together with the patching of the sound eye to enhance and stimulate the lazy one. And this stage, in my study, I followed for complete 6 months of the full correction by the spectacle and the patching together, starting the patching for 1 hour per day for 1 month, then 1.5 hours, 2 hours, 2.5, up to 4 hours per day during the period of the follow-up. Then the second stage will be the refractive surgery and patching after this surgery. The contact lens, when I got a patient with good tolerance and good behavior with the contact lens, I will left him to complete. But actually in these ages, it's so dangerous and so risky for these children to wear the contact lens because of they may miss it or got infected cornea. It's prospective study. 82 children included in this study first, and then just 11 be out from this study because of they were not compliant with the protocol of this study, so I excluded them. So the remaining 71 divided into 12 patients completed with glasses because they showed a good correction for their vision and with a response and a good response with the patching too. While the remaining 59 patients went for refractive surgery. The 59 patients with mean age of 7.3 years were undergone the corneal refractive procedures including Lassic, femto-Lassic, and PRK for treatment of that condition. The preparation in the full examination, the preparation with the psychoplastic refraction, unaided and best corrected, using the Snellen chart, the pentacam, and this image shows how this child with 4.5 years could be compliant on capturing the pentacam in our center. And then the mesopic pupillometry to consider the pupil size and the optical zone correction. The procedures were as follows: Lassic in 39 eyes, femto-Lassic in 6 eyes, and PRK in 3 eyes. Anesthesia was topical anesthesia mostly, but I used general anesthesia in the children who were under 4 years because they wouldn't be cooperative. And also the post-operative care like that in the normal Lassic patients. And these are small videos from my procedures. How to hand the flap and how to use the suction ring on the low vacuum technique to support the globe in case of the general anesthesia and in the topical anesthesia with uncooperative child. After creation of the flap, I will leave the suction ring in place under the low vacuum technique to support the eye and trying to centralize it. Then removing the flap and put it on a side, and then after laser ablation, I will reposit it again. And this is other view. This patient, this child was 8 years, so she was cooperative, and there was no need for dissection ring. And PRK with alcohol-assisted epithelial removal to get a smoother surface and easier epithelial removal with use of the mitomycin in the all cases for 20 seconds. So we are waiting for the results of that work, which the results means correction of vision, response to patching, and correction of squint. Results were depending on the type of the error or refraction. The myopics showed a marvelous improvement, either spherical or compound astigmatism and mixed astigmatism too. The high probes showed less improvement than myopics. The presence, type, and duration of squint also a very great and important factor in the results. The squint was in 29 patients with exotropia in 27 and esotropia in just 2. The type of fixation, either centric fixation in 25 and eccentric in just 4. So all these factors are very important in the results of that work. Also, it's surprising correction, really. Gain lines were much more than expected. The gain lines were 4.6 with this standard deviation lines, but with eccentric fixation, they showed longer, slower, and limited correction. The refraction was stable with increasing improvement of the visual acuity throughout the follow-up period. Patching not needed in 6 children. They showed marvelous improvement, more than 6/12 unaided. In others, it showed rapid, hopeful progress. No significant complications were reported in all groups. So I can conclude with these tables that only 26 of cases with squint needed adjuvant surgery. Patients completed with glasses showed at their most achievement best corrected more than best corrected. It's more than 6/12 and 6%. And so after 2 weeks after laser vision correction, the unaided post-operative visual acuity was 4.7, increased lines, and gaining lines with eccentric fixation as above. Gaining lines with eccentric fixation was much less, was 1.3. So at the end of the follow-up period, which 6 months after patching, they gained 5.3 as above with eccentric fixation, and much less 2.4 with eccentric fixation. Okay, we'll have just a minute to show examples of surprising cases of this work. This cute girl is 5-year-old with right high myopia and exotropia. The right eye refraction was -8. -8 sphere, -2 cylinder. The left eye was +1. With glasses and patching for 6 months, she had best corrected visual acuity 160 just. 2 weeks after Lassic, unaided visual acuity was 660, really. 6 months after patching, the unaided visual acuity was 69. The exotropia is corrected from 40 present diopters to 20. As shown in these figures. This is pre-operative, and this is post-operative after 6 months. The second case, 4-year-old girl, right high myopia, and left eye is okay. Right was -6, and also the same. With patching and the glasses, best corrected was 360 after 6 months. 2 weeks after Lassic, unaided was 660. 6 months after with patching, the unaided becomes 612, 618. The exotropia almost corrected from 45 to 15. as shown, this is pre-operatively and post-operatively. The most and the last surprising
Sir,
case.
could you please conclude this? Thank you.
Okay, this is the
2
last
minutes,
slide.
yeah,
Last slide.
yeah.
The most surprising case: 16 years old girl, left amblyopic nose squint. She was not glasses wearer, so the unaided visual acuity 2 weeks after left Lasik is 6.386. Despite the best corrected visual acuity was 460, and her age is out of the common ages of correction. So we were so happy and surprised with this unexpected results. Age, refraction, dense amblyopia. So the conclusion, anisometropy is a common cause of amblyopia. I do recommend laser vision correction for treatment of anisometropia and amblyopia if primary optical methods have failed after adequate plan in a certain time, not more than 1 year. I have found it a very satisfactory and safe procedure. So to my colleague, please don't hesitate to take your valuable and critical decision at the suitable time and following the ethics and evidence-based medicine. And thank you very much.
Thank you, sir, for a very less looked at area of treating children, especially in these cases. I have a question, and if others, before that, we have Dr. Rajesh Sinha, Professor Rajesh Sinha, who has a very large experience in this country in refractive and corneal surgery. And while he sets up, so sir, how do you ensure fixation in small children during the procedure?
The fixation simply by you mean the centric and eccentric fixation?
No, how do you ask the patient, the child, to look into the
fixation during surgery?
During the surgery.
During surgery, yeah. Okay. Either the child chose cooperation from the start on table of the machine, and by the kind dealing and by the patience with him will follow the light. I will show fixation by the pupil mark as usual in the older patients. In the adult Lasik, you will show fixation when the patient is looking at the green light in AIOC2020 machine. Will fix the green dot all the time. So if I could find that, I will complete. Otherwise, I will use the suction ring under the low vacuum technique to centralize, to help centralization and fixation and capturing the image by the machine itself.
Thank you.
Can you tell something about this low vacuum, because I don't think SBK, another machine, has got. Dr. Rohit, do you have something like low vacuums of this SBK, any of this machine? Because how do you ensure
how do you get low vacuum? Which keratome are you using?
I'm using the Moria machine.
Which one? Because the SBK and we do not have any.
We don't have a setting on SBK for low vacuum. So how do you get low vacuum?
Not the SBK, the common. The other Moria machine, which is commonly used in the microkeratome, the microkeratome, not the SPK.
Can you enlighten us on the previous version of the Moria machines?
Yeah.
So do you have that concept of low vacuum on any of these?
Okay, I think we'll let it leave at that. Thank you, sir, for
just a word. The normal vacuum used. What's the normal vacuum used in the Lasik cases? With the Moria?
Around
60?
No, the machine which reads, I think it is around 700, Rohit? Around
600? Yeah. I'm going down to 4.
Can you do that?
Yeah.
Thank you.
Okay.
Thank you, sir. Yeah, Dr. Sinha, please.
Thank you, Dr. Kapoor. It's a great pleasure to be here in this wonderful course, and I'll be talking about few things about corneal haze after surface ablation, a little bit about regression after Lassic. So surface ablation means PRK, Lassic, alcohol-assisted, or epipolis, laser in situ keratomiliosis, and all these things have evolved because we have seen haze in PRK. Over the years, it has been seen that haze can be seen in PRK, and this is something it looks like this is the typical appearance of a subepithelial haze. And the risk factors can be higher ablation, high refractive error correction, retreatments, previous corneal surgery, poor ocular surface, and basically it is the exaggerated corneal healing response, and it is actually the interaction between the inflammatory mediators of the tear film and the keratocytes that results in fibroblast formation, and that results in a haze. So the haze can be transient, which normally appears between 1 to 3 months post-operatively, and it resolves mostly over a period of a year. And patients usually are not with much symptoms, and that is why the clinicians are quite happy that okay, it's not a significant haze. Sometimes you can have a late onset corneal haze which occurs later in a couple of months and then can last for longer period. And some hazes can remain like that forever. So people have tried to quantify haze by various methods, by confocal microscopy, by Scheimpflug densitometry, and there can be subjective grading also depending upon the visibility of the structures behind the haze. And ConfoScan also has been used to see the haze. As you can see here, the in between keratocytes, this is pre-PRK confocal microscope, and this is post-PRK. So in between keratocytes, you can see this myofibroblast fibroblast present. So this actually is a way to quantify haze. The basic idea is to create a management protocol so that you can, say that with this kind of a grade you have to do this. But the best thing is that you should try to prevent haze, and that is basically done in PRK by use of mitomycin C, and we all are using it. It inhibits cell mitosis, and we use it mostly, although there are various concentrations that have been used, 0.02% for 2 minutes, for 1 minute, for 30 seconds, 0.01% for 45 seconds. All these things have been used, but mostly people use 0.02% for 30 seconds, and that is what we also follow, and this is what US Army study has recommended, that PRK with mitomycin C, 0.02% for 30 seconds had no measurable level of mitomycin C in blood, and that is why it is safe, and it also results in preventing haze to a great extent. Although in spite of all that, studies have shown that nearly 1/3 of individuals, they do have some degree of corneal haze. Now some haze may not be significant clinically at that point of time, and the patient can have good 6/6 vision. But this haze may become significant once this individual grows older and has to undergo a cataract surgery and wants a premium IOL. In that case, this subtle haze can become significant and can have a suboptimal outcome with a multifocal IOL. Now there are other agents like topical steroid is something which is very often used to prevent haze. This is, I guess, apart from mitomycin C, it is the steroid that is most routinely used for preventing haze. High dose vitamin A, vitamin C, all these things have been used and have been found to be helpful. Studies have shown proven efficacy of all these. Now anti-TGF drug, that is trichostatin A, has been used experimentally. And normally what happens that there is a TGF beta 1 and beta 3 for the healing response. Now the T1 has been shown to drive the corneal keratocytes to differentiate into myofibroblast, and T3 inhibits the fibrotic markers. So if you can suppress the T1 stimulation by introducing T3, that can prevent haze formation. But this is all experimental studies, in vitro studies, and that have not been used in human eyes. As this study shows that, as I was mentioning earlier also, that 1/3 of individuals do have some amount of haze in spite of mitomycin C and ascorbate, which may not be significant clinically at that point of time, but later it may become significant once the patient has to have a premium IOL in the eye. And what all these modifications of surface ablation have been shown, even the trans epithelial PRK, the double stage, 2 stage, 1 stage, all have shown some degree of haze with correction. And if there is a haze, then 2-3 things that you can do. One is that you can do a superficial debridement, use topical mitomycin C. You can polish it with diamond burr. It is, unfortunately, I haven't put the video. I've done it in a case, and diamond burr has been used routinely for pterygium excision. When you remove the pterygium, whatever scar is there, whatever irregularity on the cornea is there, you can polish and make it smooth and regular by use of diamond burr. The same can be used in these cases. And of course, you can do a PTK with mitomycin C. So this was something about haze, and a little bit more that I've been asked to present is about post-Lassic regression. Now, regression means you have corrected an individual with Lassic, the refractive correction has been done, and now the patient has come up after some time, after months and years, with some refractive power, requiring glasses, requiring contact lens, and basically regression has been shown to be caused by increase in central epithelial thickness, or there can be a keratocyte hyperplasia or hypertrophy. There can be a corneal forward shift. There can be corneal ectasia. So all these can result in some degree of corneal refractive regression after refractive procedure. And if you have a regression because of the refractive power coming in without any ectasia, in that case you can do you can relift the flap and you can do a re-Lassic. Now, the microkeratome flaps are easier to be relifted than the femtosecond laser flap because of, obviously because of the configuration of the peripheral part of the flap. Now, once you lift the flap, you can ablate it, and you can reposit the flap back. Now, surface ablation can also be done in these cases because one complication that has been noted after re-Lassic is epithelial ingrowth. And if you find that the flap is not lifting up easily, there's no point struggling and forcing the flap to relift. You can go ahead and do a surface ablation in order to prevent the epithelial ingrowth because of that. And if you have done a femtosecond LASIK, you can do a recut, and that you can do inside. You can do a side cut within the initial flap, and you can go ahead and complete it. So it's a vertical side cut that is done, and you can lift another flap at the same depth. So, and if you have a regression because of ectasia, which can be seen, you can have ectasia because of higher ablation, because of inappropriate selection of case, because of some more factors which perhaps we are not aware, because sometimes ectasia has been seen even in conditions which were absolutely fit for refractive procedure, and they had ectasia. So the individual ocular surface, individuals mediators in the tear film, the hormonal changes, all these things can be factors that can lead to ectasia in spite of taking all the precautions. And if there is an ectasia, in that case you can do a RGP contact lens fitting, and that is the mainstay for any case of ectasia. It provides a very good vision. And if the patient is not willing for contact lens fitting, then intracorneal ring segment is one good option which can be tried in all these cases. Now, this is an example of a femtosecond assisted intracorneal ring segment implantation, and I'm sorry. Yeah. So what you normally do is that you place the suction ring and applanate the cone. Applanation done. Yeah, that's fine. That's fine. That's fine. Leave it. And then the radial incision is opened up. The initial part of the track is opened up with this mechanical separator. And once you have done it, then you can place the intracorneal ring segment. And once you have placed the intracorneal ring segment, you can debride the central part of the epithelium within the ring segment, and you can do cross-linking. So this is one good option if the patient is not tolerating contact lens. Just one point I would like to highlight here is that in case of post-Lassic ectasia, it's better. Most of the times they have astigmatic errors. So in those cases, we have to judge what type of ring segment we have to use. In order to correct astigmatism, in all these cases, it's better to use one segment or asymmetric segments of intracorneal ring segment. Thank you very much.
Thank you, Professor Rajesh. Are there any questions? Our last but not the least speaker, Dr. Rohit Shetty, who is today training most of the young ophthalmologists who are not only a clinician, but scientific temperament by far in this country, the maximum. And thank you, Rohit sir, for joining us.
Thank you, sir. Can ask some questions in case. Yeah. Thank you, sir. Thanks for this course again. This is, I'll try to avoid any repetition from what has already been discussed so far. These are my financial interests. My talk will go on this 4 questions. Why do you need a PRK? How do you do a PRK? Controversies and demons, and what's the future? The question why is because we have different types of topographies, and not all topographies which are suspicious should be excluded. Sometimes we don't have a clear picture. Sometimes it could be just a variant of normal. So avoiding a LASIK for somebody who has a good topography, but it's a small deviation, may not be the right way to do, especially in that era of having so many epithelial changes and all those factors. So PRK is considered that way for many, but in fact, in many places in the world, it's the first line of treatment. That means they don't even touch the refractive procedure other than this smile, so other than the PRK. So you can choose that. And how do you do it? It depends on how you take the epithelium off. The lasers are just the same, whether you do an alcohol, whether you do a manual debridement. I prefer now, the last 3 years, a completely change is the all-in one-shot procedure, the trans-PRKs. Now Alcon also has the same one, but my experience has been more with the trans-PRK of the Schwinn. So the second question is how and why it should be done. This is where the big challenge comes. The whole idea of PRK is that it's more stronger, more forgiving, but we still don't know the true picture. So because we don't know the true picture, the question still lingers. So we did this study. This is the first of its kind. The most important thing in any procedure is to see how the collagen is. Unfortunately, there are not many technologies which can evaluate or check the collagen. So this imaging the collagen completely opened up a new avenue in understanding. And this is a custom built. That means we built this OCT, which is called the polarization sensitive OCT, works on the principle of polarization. Now at this point of time, it occupies the whole room. But eventually, like all OCTs, it will probably come smaller than this laptop one day. So how does it look? For example, this is a diagrammatic representation of how a collagen is. It has this strong pillars in the periphery, and you can see the center is different oriented. This is how a collagen of your cornea. So when we image this, this is exactly what it looks. The blue area is different. This is those fibers at the periphery, and this is how normal collagen is. So it's important that the reason I'm saying is this will help us to understand what procedure and how it's helping, and this is how orientation, like what you call it as the orientation of the fibers. That's what makes the cornea change that way. So when we look at patients who don't have a perfect topographies, these are all patients who don't have a perfect topographies, and we image the collagen because topography is not the direct link to what is happening in your collagen. And you can see that in this case, you can see that the collagen is completely low. In this case, this is suspicious and you hardly see any collagen. This is normal. This is how a normal should be. But this case also looks a little suspicious, but the collagen is exactly the same as the pre-op. So that means there is so many variations in this. So what we did was we did the PRK, one eye. This was anyway normal. We could do the smile. So we did the PRK. and this other eye went into Smile Extra. Very interesting find. When you do any cross-linking procedures with LASIK, it should bring in strength. The collagen should look better or stronger. But when you do the same Smile Extra, where you pay a lot of money, and you do a PRK, the collagen orientation is bang on. So that means the PRK alone gives you the same strength or more strength than a LASIK one. This is LASIK. You can see that this whole area out here is weaker. This is a flap. This is a flap. And in PRK, there's no flap. And you can see, compare this with normal. The PRK eye, after you do the surgery, actually becomes, the collagen orientation is much closer to a normal than what you see in a LASIK. And a Smile Extra is actually doing some benefit, but without doing any extra procedures, you are exactly getting the strength. And in this patient, we did not do any surgery. So what we are trying to say is, there's tremendous amount of strength in PRK. The collagen orientation is much well preserved. And when in doubt, you should remember this slide. And this is just going out to be a publication. This is the first of its kind when we are looking at the collagen directly. And you can just see the comparison between this. The third question is, what are the demons? The two demons which we have in our with us when we plan is your pain. The pain is always a major factor, and haze is beautifully covered by Rajesh sir. This is a paper which we published about using the AccuVeil. AccuVeil, I know the first question, you don't get AccuVeil. I've worked with at least 2 companies now, helping them to develop it. But in the next 2 or 3 months, you'll get a preservative-free, exactly the same AccuVeil, which can be used everywhere. Otherwise, we had to beg, borrow, or threaten the company Elegant to give us this drops. But I think it will just going to be used freely. So it makes, this is how we do it. We just inject 0.2 ml AccuVeil. We did a lot of chromatography experiment to see why we need to inject for 20 minutes. What is it? Because it needs to absorb. Why need to be covered? Everything. A lot of this question, why not just soak in? Because it takes that much time for it to get absorbed on the surface. So pain score is virtually nil now in my practice. So I have majority of my patients offering PRK, and they're completely comfortable. I usually do 1 eye at a time just to see how the score is, and it's absolutely just like a normal factors. This has been described by Dr. Rajesh sir, but I'll just tell you, this is a paper which published in Scientific Reports by us just a few months back of what factors really drive haze. And we had stored this epithelium in our lab during the procedure. So when patients developed haze, we had to go back to our same repository and take those and figure it out. So what we found was all this has been explained. There's a waves of healing changes. Of the patients who developed haze, one of the major factors was low vitamin D deficiencies, a high OSDI, that means they were contact lens intolerant, and patient had huge amount of ocular surface inflammation in terms of MGD. That means whatever was ocular surface was actually the driving factors. How does it play a role? All these things, including contact lens intolerance, play an important role in the corneal nerves. And these are your dendritic cells. If the nerves are unhealthy, so your response to healing is going to be very unhealthy, and this is going to create a change. This is exactly what happens. So what we did was we looked at all these factors, the OSDI, vitamin D, contact lens intolerance, the amount of gland loss you have, the working environment. This is very important in case of late onset haze. Most of the patients, when they come to me and they developed haze late onset, I ask a question, did you relocate to a different place? If you are staying in Bangalore or a high altitude place and suddenly the patient goes and relocates to Mangalore or Chennai or some other place where there's more UV light, the trigger of factors could change. So one question is about change in the position. Or sometimes they say that I'm getting the LASIK surgery done in Bangalore, I'm staying for 2 months and I'm going to relocate somewhere else. Then I tell them you need UV glasses more frequently. And we build this score, which is just on the process of validation. And we call it as a predict perfect score, where we're looking at validating them, which I'll share with you sometime. And based on the risk score, we try to change the medications, what type of drops we use, how long we use, because we feel that these things really help in getting much better outcome, especially when you're looking at the haze as a factor. And our preoperative regimen also changes along with this care, because one haze patient out of 1,000 is still a pain, because they're going to make you lose interest in that procedure. And again, intraoperatively, Even the AccuVeil works in this phase. So even giving an early AccuVeil, the soaked contact lens actually reduces haze to some extent. I've spoken about mitomycin, and when we did the prospective one, we were able to reduce it much more than what we have, and we have now close to 3 years of data on this. So what do we get here? Is more safe and predictable. There is link of laser to your biology, which has been explained by me and Dr. Rajesh sir. This is something which is work in progress, and I still believe that it's one of the strongest procedures, and PS OCT did prove that clearly. Thank you.
Thank you, Dr. Rohit. First of all, congratulations for the extraordinary work that you're doing. Any questions? Yeah. Address him. No, to this talk. Any question for this talk?
He wants to ask question.
Come here.
I had one question, like for a general ophthalmologist who wants to go for refractive surgery, what do you advise that it should start with ICL or it should start with Lassic? And what you will suggest us to improvise his refractive? I am Dr. Piyush Mohan Agarwal and I am from Bareilly, Uttar Pradesh.
So may I first request the practicing ophthalmologist, Dr. Rohit Shetty, who is in private practice. He wants to know if he wants to start refractive practice, should he first do ICLs or first Lassic? PRK. Professor Sinha?
Yes, definitely. I would agree. PRK will be the simplest to do, and he should start with PRK.
Jivan?
His question is that whether he can start ICL. I think he can start ICL.
No. Where he wants to start refractive practice, should it be with ICL or surface procedure or Lassic, etc.?
ICL.
RC?
I think it doesn't make any difference. Almost all of them are same because you have a different indications for each one. And flap making is not that difficult.
Sartaj?
I think as far as surgical technique and safety is concerned, they're fine. But the advantage with ICL is you probably already have the infrastructure in place if you're already doing cataract surgery. So while you wait to sort of set up or find a place where you can start doing laser ablation procedures, at least with ICL you can start.
I think I will differ with my young colleague, and I would go with PRK, Lassic, and ICLs after a year of getting used to refractive surgery patients. Thank you. Any other questions? Yeah, madam, can you come to this mic, please? Please ask anything related to starting refractive, anything. Yeah.
So for the surface procedures, do oral steroids have any role in the haze, sir?
We don't have a portable mic, but Rohit, can you just say?
I don't think based on studies, there's no role of oral steroids to prevent haze.
And for the topical steroids, even before the epithelialization is complete, do we start over the bandage contact lens itself? What we've usually been practicing is once we remove the bandage contact lens and we are sure that there's no epithelial defect left, after that we start topical steroids.
Absolutely. Actually, that's what is general practice, that once there is epithelial healing, after 48 to 72 hours, you start steroid. There is one study which states that if you start steroid before epithelial healing from day one, the incidence of haze was lesser. That is one study which has compared and has stated this thing. But apart from that, general practice, I think, we also follow that for 48 hours, we don't give steroid, and after that we start. Your same.
Rohit, you don't start the steroid till the bandage lens is off? But I think, if you're covering the patients with your NSAIDs, well, then that is also a factor, even though.
I would slightly differ on NSAIDs because if there's any corneal surface defect, anything, then NSAID should be avoided.
Yeah. So there are a lot of views on this. I don't do many PRKs. I do about 300-400 a year. But I start steroids from immediately on the table as soon as the procedure is over. I haven't had a problem in the last 3 to 4 years. Before that, I wasn't doing PRK. Since recently, it's come into fashion, and
So you start with prednisolone acetate or some low
anything,
dose?
anything. If it could be Abdrop PD, a combination of any steroid antibiotic.
Actually,
Right.
I would say that if you're using Predastate, what happens is there's a lot of deposition, and you have put a bandage contact lens also. So it's better to use Pred phosphate in those wherein you have a clear solution.
And in all kinds of refractive procedures, we are practically not using any NSAIDs. So is it really recommended, even whether it's Lassic or PRK?
Is
That's
Rohit
what I was.
sir is using AQL only?
The contact
Oh,
lens.
not, but the bandage lens? Oh, bandage lens only for 6 hours. Oh, so the AQL.
What you use is only for 6 hours. When you soak
Oh, it's not
contact lens.
topped up again.
No, it's not topped
So
up
there's
again.
no NSAID after 6
No,
hours.
no. It's
yeah,
just
so then it's
so that's why we compared the wound healing. I mean, this is the first question, and the most of the issues related with delayed or melt was more from the Voltaren, the diclofenac. Thing. The AQL has some component. That's why it's a preservative free, and we did not see, even in the paper we have mentioned, that was we did not see any difference in wound healing compared to the eye, where it was a placebo. It was not under the depot. So we are not loading it after thing. It's just the depot, and it lasts for the deposition of this lasts for 6 to 8 hours, where the maximum pain is.
Pain. It's basically for pain
It's
relief.
just
But
the pain
is there any harm in giving pain relief for a longer time with drops, maybe NSAID drops?
See, the basic idea is the pain-related factors when you make a PRK is maximum between the 6 to 12 hours. So, 0 to 12 hours. If you are able to knock it off, even if you use continuously, it's of no use. It's the first 24 hours which is very
important.
crucial.
Yeah. Yes, sir. Could you use the mic, this mic, please? Yeah.
About your question about the low vacuum technique, I brought it from the official site of the Moria SA, the Moria machine. There is a button, it's called low vacuum button. When the targeted vacuum is 760, okay? And the low vacuum is down to 250. Could be catching the eye down to 250.
Which model?
Moria SA.
S.
SA, not for SPK.
No,
I can show it now.
No,
Yeah,
it's okay. Thank you. It's just that most of us have SPK, which is the current model in refractive surgery. So that option is not there on the SPK.
No,
Yeah,
this
thank
is the
you.
Moria I'm using with
Yes,
the
sir.
alligator machine, and,
Yes,
and
sir.
I have done a lot in my practice
Thank
about
you.
the low
Thank
vacuum
you, sir.
technique. Thank you very much.
Kagadia Sahib, last question. I think the next guys have come.
Not a question, it's a comment. With SBK Moria, if you wish to achieve low vacuum, you just puncture the line with a 26 gauge needle, and the vacuum will drop down by 1/3 or 1/4. Depending on the size of the gauge of the needle, you can achieve, do a little trial and error, because I have been doing many surface ablation under GA, and because many of the very uncooperative patient at the age of 15, 16, sometimes we do like sir is doing, you just puncture the line and the vacuum is broken to half or 1/3.
Thank you, sir. Thank you all the participants and the audience. Thank you.